project, I think, thank you, Sally. I think it's one of the best and most patient-oriented, well-done researches I've been a part of or seen. So I'm very happy to talk about it with you guys. So I'm a patient partner. I've been in the patient partner space for over 4 years, since I became a qualified patient. I have aphasia. So if you don't know what I'm saying, so aphasia is when your brain doesn't communicate with your mouth or cannot find words. So sometimes I will be mumbled. If you don't know what I'm saying, just ask. I've been in this project involved from the beginning, so now 2.5 years. The first 2 years I was co-chair on the patient side. Now I stepped down, and will pass it down to Annie.
Hey, thank you, Veronika, and good morning, everybody, and thanks for inviting us to present here today. My name is Annie Rychtera. I call in from Silverstar Mountain, what is on the traditional territory of the Saugeen Nations in BC. I'm a patient partner as well with the project from the beginning, and now I'm the co-chair for the PAC, or one of the co-chairs for the PAC meeting, PAC committee, sorry. And I'm fighting with a real bad cold, so same thing, plus I have an accent. So if you can't understand me, or if I mumble or lose my words, so please excuse me, but feel free to ask if something wasn't clear. So we, like Veronika mentioned, we are here today to present this paper, what you can see on the slide. We are co-authors on this paper together with many others. The names are all listed there. More patient partners as well as academic partners on the project. We also got sponsored, want to mention that, by the Alberta SPORE Unit, the Canadian Institutes for Health Research, Alberta Health Services. These were the partners in the beginning. It was more concentrated to Alberta, but now it branched out to BC as well. So the BC Support Unit and our health authorities are involved as well. We had said we are part of the REPORT project, what stands for Repurposing the Ordering of Routine Laboratory Tests in Hospitalized Patients. Next slide, please. So why did we do this project, and what were the reasons? And we found, like out from literature research as well as experience, that there is a knowledge gap from knowledge. There's a gap from knowledge to practice, I should say, in the optimal use of lab testing. And over-testing use really leads to negative outcomes. So we all know and we appreciate that for patients, lab tests are important, and lab tests are used for screening, diagnosing, and monitoring medical conditions. An average Canadian receives between 14 to 20 tests a year, and that makes lab testing the most common medical activity. Lab test overuse occurs when tests are ordered without really consideration of the effect the test has and the probability of the disease. Literature showed that an estimated 16 to 56% of lab tests provide no clinical value. and often are unnecessary, repetitive, especially the routine testing, really leads to negative outcomes. Like it could harm patients in terms of even leading to anemia for repeated testing and massive testings, but also just the impact in terms of the needles and the disruption often in their sleep. It definitely leads to healthcare waste. So it's a waste of resources, time, and money if there is no clinical value to the test. As well, it has a really ecological impact. And everything is just one-time use, and the impact on the environment is substantial. So we do appreciate that lab testing is important for patient, and but like we also have to make sure it is used appropriately. If we want to drive change or introduce change and then drive change, we really have to work with patients and the public, and we have to understand what the patient experience is to identify the opportunities to improve the patient engagement within the hospital lab testing. And I hand it over to Veronika of this slide. How do we reduce the overuse? I mentioned that before. We really have to work closely with all medical staff, including the doctors who are prescribing the tests, as well as working with the patients, the caregivers, and the public. And patients involved as study participants to learn about their experience, but also patient involved as research partners, that we make sure we ask the right questions and get meaningful outcomes for patients and public. And now I hand it over to Veronika.
Thank you, Annie. And today we'll focus on the patient side of the study, but there's also a doctor medical staff side going on in parallel to what we're researching with the patients. So as Annie said, we need to involve patients not only as subjects, but also as research partners. So PAC, as Annie mentioned earlier, Patient Advisory Council was formed, and it included patient partners, patient engagement team support, and of course, academics. So academics were of course, the study PI and other team members on the academic side. The patient engagement support came from the Alberta Sports Support Unit patient engagement team, and they made sure that patients and researchers can work well together in a meaningful way. And for patients, we had 11 patients, and I wanted to note one characteristic about our patient partners, which is something we all strive for is diversity. So diversity in experiences living with multiple healthcare conditions, in research, and diversity with experience in the blood work and being in the hospital at all. So some of us have never been to the hospital, like in the last many years, and some of us are frequent flyers. And of course, age, gender, ethnicity, and so on as well. And the PAC was co-chaired by research study coordinator from the academics team and 2 patient partners. So as I mentioned, I was one of them, and Annie is one now. So how did we work together? We had monthly meetings. It was a only requirement for patient partners involvement that you attend monthly meetings, and that was the space to do all the meat for the study, make all decisions. And then if you are patient partner more interested in a specific area of the project, you can join the working group. So we have had three. For example, one of them was data collection working group, and very involved in this particular study, of course, data analysis working group, and so on. And we had lots of learning opportunities, mainly provided to us by Apps4U team. We got to build up our capacity, knowledge, skills, and we got experience to how to conduct patient interviews, how to do thematic analysis of transcripts, and so on. And basically here, we strive to include patient experience and perspective in meaningful and equitable ways at all phases of the research project. So PAC members were even co-applicants on grant funding. We were there to co-write the ethics proposal, and we were deeply involved in study design. So interview guide, consent forms, all the materials, recruitment materials and strategies, data collection and analysis, so patient interviews, implementation, evaluation, and dissemination of results. So co-writing the paper, and, for example, be here, knowledge translation efforts. And I'll pass it on to Annie again.
So to really understand the patient experience, we had to really get into details to trying to listen to patients and caregivers to strive to understand their experience to drive change. Our PAC members were really instrumental, as Veronika demonstrated, in designing and conducting this research project. To introduce change, we really need to work closely together, and that's why we designed a qualitative study using semi-structured interviews. It's we conducted a multi-hospital study between May 2021 and June 2022 across Alberta and British Columbia. We used convenience sampling to recruit participants. Recruitment posters were widely distributed, and we also put it up on social media. And we used convenience sampling then for the thematic analysis. So participants were adult patients and family caregivers, 18 years of age and older. And the criteria was that they had to be hospitalized and blood tests done within the last 12 months of the interview. And like we said, it was within BC and Alberta. We identified participants through the convenience sampling and conducted the semi-structured interviews. And at the interviews, there was 3 people. It was a note taker from the research team and an academic, as well as a patient partner involved. So the analysis, hang on, I just have to go to the right slide here. Sorry about that. We used thematic content analysis of the interviews, transcripts, and after we finished the interviews, we did the analysis what showed 4 themes in total. The first of which is information and education. And for that, I hand it over back to Veronika to explain more about it.
Thank you so much, Annie. So yes, in the 16 interviews, 4 themes were identified and interviews were conducted until thematic situation. So no new themes were coming out. So we stopped at 16 interviews. So we had 4 themes coming out. So the first one was information and education. Patients require clear information and education about the process involved in a laboratory blood testing within the hospital setting. So just make sure, because this is all about the hospital setting. So every time I say blood testing, it's automatically in hospital setting. So they need to know what's going to be done and when. So patients know tests are important, that there's a lack of clear explanation at the beginning of a hospitalization regarding what they could expect about the process. Most receive little or no communication about the tests. And interestingly, none of the participants interviewed had explicitly been asked for consent before blood collection. So recommendations coming from the participants were that they want to be asked. So process of informed consent, either written or verbal is crucial. That overview of blood testing process should be provided. And the timing of those discussions should consider patient cognitive and physical limitations. So some said, when I just came to the hospital, that was not the time, but maybe the next day, maybe in 2 days, when I actually can understand what's going on. The second theme was the process of drawing blood for the test should take into account the comfort and preferences of the patient. So patients appreciated when the blood draw process were performed in a gentle, empathetic, and accommodating manner, because some had more painful experiences with even some extensive bruising on arms. And many were very frustrated with being woken up for blood taking process. So early morning, late nights, and most of us, if you've been to the hospital, you probably experienced this a wonderful benefit or side effect of blood testing process. So recommendations: consider patient preferences. So some people have a preference for an arm to be used. Some people prefer having hot towel to bring up their veins, and so on. And they want to be provided with schedule of blood draws. So like, let us know when you're coming, and nothing that will wake us up. 13th theme was patient desire explicit information regarding the rationale behind and frequency of laboratory tests. So testing process appears to be not inclusive, and lack of patient involvement was frustrating. However, people still do trust their healthcare team to make proper decisions about the frequency and amount of blood testing done, but they want discussions, they want information. And some caregivers said that they were frustrated because they did not feel included in the process anyway at any point. So recommendation is very simple: actively involve patients. Everybody was pretty clear that they wanted to be in the loop about their care. Some needed more details than others, but at the end of the day, they just wanted their healthcare team to keep them informed. And some recommendation was also use a written communication and whiteboards that are in the rooms. And I found this quote pretty powerful from one of the participants. Everybody has autonomy, empowerment, and power over their own health, and should be involved in absolutely everything to the degree that they can be. And the last theme, that there's a need for information and education on how the results influence the medical care itself. Patients receive limited communication about results, even though they knew they can go online and they can ask for printouts of their test results. Patients often felt too overwhelmed being in the hospital to check them out. And some people said, yeah, I got all my results at the discharge, but it's just too much information, never actually looked at them. Recommendations, also pretty straightforward. Patients express that ongoing conversations with a healthcare team are crucial for understanding changes in their health status. One caregiver even proposed that adding a patient family advisor to the team could lead to more patient-centered care. They felt that clear communication about the tests and results, preferably from the doctor or the nurse, was essential for them to fully grasp their health situation. So that's our 4 themes, and I will pass it on to Anna for the limitations of the study.
Thank you. So now that we discussed the findings and the recommendations, we want to mention a few of the limitations of the study. As mentioned, it was done during COVID-19 pandemic, and that's why we chose the convenience sampling. A limit of the convenience sampling is motivational bias, which is a bias that results from being invested in a specific outcome. For instance, people with negative experience in blood testing, they are more willing to speak out about it and share their experience. We also had the risk of limited cases, and that's a weakness, what could lead to limited diversity. Another limitation mentioned here is recall bias. That's when you go back in time and try to recall an experience in your memory, it can lead to differences in accuracy of the event from the past. The poster in Alberta could be just shown in 2 different hospitals, and they were urban. Posters were in English language. And also, like I mentioned before, the interviews were introduced or were conducted in English only. But as evidenced by similar experience and recommendations of the participant, we can say that the findings are relevant and important, and they really do reflect the experience with different hospitals in 2 Canadian provinces. So the conclusion we came to, what we learned from our studies, is that the current laboratory testing processes in the hospitals do not facilitate shared decision-making and patient engagement. It is still comes from top down, ordered, and patients following and the orders. The patient engagement with laboratory testing in hospitals requires an empathetic healthcare team, what provides time to really clearly communicate regarding the testing procedures, the rationale, listen to the patients, and really explain then at the end the results. What does it mean to them, and how do the results influence their healthcare plan? And the second point, important point, is really considering the patient comfort and preferences as much as possible, and offering opportunities for their involvement. to have a good dialogue with the patient and the caregivers to provide the best outcome possible for everybody involved. Next slide, please. We did some, this slide is just the references. We mentioned like the literature research, we referenced sources in the paper, and here's more information about it, where to find them, and where we draw some data from. And for your information as well, we put out some knowledge translation outputs, and we created a website where you can find links as well as our infographic co-designed with patient research partners, as well as the video. So please go to our website and check it out if you have not done it so far. Thank you very much for your attention, and now we are open for questions.